Hi. Good evening, everyone. Today we are starting our MEC a bit later because there was supposed to be another conference here going on. But we are glad to have our own junior faculty, Dr. Zakaria Sibai, present on the topic of medullary thyroid cancer. Dr. Sibai did his MD at Aleppo Medical School in Syria. He did his internal medicine residency at Brookdale in New York, and his fellowship in endocrinology here at the University of Louisville. We were very happy to have him here as our faculty starting from July of or August of this year. He has been an excellent fellow and an outstanding faculty so far. He will present today on this topic of medullary thyroid cancer.
Thank you, Dr. Makshkanda, for the introduction. So thank you, everyone, today for joining us for our endocrine ground rounds. And today I'm gonna discussing the topic of medullary thyroid cancer. So I have no disclosure. And learning objective for today, first we're gonna talk about a little bit about the etiology of medullary thyroid cancer, and then we're gonna move to the diagnostic step of medullary thyroid cancer in patients with thyroid nodule. And then we're gonna highlight the importance of calcitonin level during the pre-op and the post-op period as a biomarker for prognosis and long-term outcome. And at the end, we're gonna discuss the role of radiation therapy and systemic therapy for advanced and metastatic medullary thyroid cancer. So some background about thyroid cancer in general. Thyroid cancer is considered the 12th most common type of cancer in the United States. Estimated new cases in 2022 about 43,000, which count for about 2.3% of all new cancer cases in the United States. Death rate in 2022 about 2,230 cases. Over the past 30 years, the incidence of thyroid cancer has been increasing, and whereas the incidence and the death rate has been stable. And there's multiple factors that contribute to the increase of the incidence of thyroid cancer. One of the most common cause is the increased use of diagnostic imaging study like CT scan and MRI, and which lead to incidental finding of thyroid nodules, which lead to evaluation and then diagnosis. Usually the incidence rates of thyroid cancer is 3 times higher in female compared to male. And when we look to different ethnical group, usually the non-Hispanic Black population have the lowest incidence rate of thyroid cancer. Thyroid cancer is most frequently diagnosed among people between age 45 to 54 and 55 to 64, about 21%, and the median age at diagnosis is 51. Regarding death related to cancer, usually the highest death due to thyroid cancer, highest among people aged between 65 to 74 and 75 and 84, and the median age at death is 74. So as we all know that thyroid cancer can be classified into different subtypes. We have papillary thyroid cancer, counts for between 70 to 80%, follicular thyroid cancer between 10 to 15%, Hürthle cell carcinoma 2%, and medullary thyroid cancer about 3 to 5%, and the least common thyroid cancer is anaplastic, which is count for less than 1%. And today I'm just going to highlight about medullary thyroid cancer. So starting with the etiology of the medullary thyroid cancer, it arises from the parafollicular cells, which also called the C cells, which is located between the follicles of the thyroid glands. And usually they count around 1% of the thyroid cells. The C cells are called by this name because of their ability to secrete calcitonin and also to secrete carcinoembryonic antigen. Talking about the molecular cause etiology of molecular thyroid cancer, molecular thyroid cancer has been strongly associated with RET gene mutation. But how does that happen? RET gene, it stands for rearranged duration transfiction proto-oncogene, which is located on the long arm of the chromosome 10. The function of this gene is to encode protein that's part of the receptor tyrosine kinase. This receptor, when stimulated, sends downstream signaling through multiple pathways, which are essential for the cell differentiation, survival, migration, and apoptosis. So when any mutation that happened to the red proto-oncogene, that's lead to overexpression of receptor tyrosine kinase, resulting in increased activity in the cellular pathway, and this process is responsible for the tumorigenesis. Red mutation is a remarkable oncogene that's not only central to the development of MTC, but also important for the development of other malignant and non-malignant diseases. Medullary thyroid cancer can be classified into two categories. First, the hereditary medullary thyroid cancer, which all patients in this category had the red gene mutation, and it counts for about 25% of all MTC. And hereditary MTC associated with syndromic disease. And you know that MEN2A, almost all patients develop MTC, but lower number of patients develop pheochromocytoma and hyperparathyroidism. Also, MEN2B, all patients mostly develop MTC, but usually it's developed earlier in age and usually higher, more aggressive. And the last one is familiar MTC, which is defined as families with red mutation and MTC, but without pheochromocytoma or hyperparathyroidism. The second type of MTC cancer is sporadic MTC, which got about 75% of all medullary thyroid cancer. 50% of these patients have red mutation. The other half, they don't express this gene mutation. And usually occur during or between the 4th and the 6th decades of life. And about 70% of patients with MTC who present with palpable thyroid nodule, they have already cervical metastasis, and 10% already have distal metastasis at the time of the diagnosis. The 10-year survival rate for patients with stage 1, 2, 3, and 4 goes between 100%, 93%, 71%, and 21%, respectively. So one unique thing about MTC is kind of considered one of the neuroendocrine tumor due to its ability to secrete different hormones or products. The first one is calcitonin, which is kind of very significant and has important value for MTC because of its role in the diagnosis, management, and long-term prognosis. And serum calcitonin usually increase due to other causes like CKD, primary hyperparathyroidism, autoimmune thyroiditis, small cell and large cell lung cancer, prostate cancer, and various enteric and pulmonary neuroendocrine tumor. In some situations, we can get falsely elevated calcitonin level due to heterophilic antibodies, and sometimes we can get falsely low calcitonin level due to hook effect, which is similar to what happens in people with prolactinoma. The second hormone or the product that MTC secrete is CA, carcinoembryonic antigen. Also, it's not specific biomarker for MTC. It can be positive for other tumors. Falsely elevated level can occur also with heterophilic antibodies, people who smoke, with GI inflammatory disease and benign lung disease. But similar to calcitonin, CA has significant value in the diagnosis, management, and long-term prognosis for MTC. Other hormones that can be secreted by MTC also ACTH, which can lead to Cushing disease, and other hormones like chromogranin, histamines, and neurotins. So going to the diagnosis of medullary thyroid cancer. It usually starts similar to any other thyroid cancer with thyroid ultrasound, and based on the ultrasound's and thyroid nodule characteristic, we can go ahead and do FNA for the suspicious thyroid nodule. And based on the FNA cytology, there are multiple findings for MTC, which is important to recognize to differentiate MTC from other differentiated thyroid cancer. We can expect to find giant cell. As you can see here, there's like a giant cell in the middle with a large nuclei. And we can expect to see binucleated cell, which is mean one cell and has two nuclei inside it. And also we can see what you call it the salt and pepper appearance. As we can see the cell in the middle, there's like multiple small dots, purple in color, and that's due to the presence of chromatin. This is kind of specific for MTC in cytology. Other finding on cytology, we can find the spindle shaped cells, and also we can find the presence of amyloid, which is, this is pinkish yellowish material on the slides. But what is the accuracy of NA in the diagnosis of medullary thyroid cancer? If there's any difference between the accuracy of FNA in diagnosis of differentiated thyroid cancer or in diagnosis of MTC? So this is like two studies I found trying to evaluate the accuracy of FNA in diagnosis MTC. One study, they had 34 patients. The second one had 91 patients who has verified MTC by surgery. And they did they reviewed the cytology slides for the FNA, and they found that FNA was accurate in 80% of the patient in the first study and 89% of the patient in the second study, which is almost equal to the accuracy of FNA diagnosis in other thyroid cancer, like follicular and papillary thyroid cancer. But in some situation, we can get negative cytology for medullary thyroid cancer, but we still have high suspicious for diagnosis based on patient family history or presence of RET mutation. So this patient, we really need to make sure that we're not missing this diagnosis. One of the tools that we can use is doing the immunohistochemistry. And we expect in patients with MTC that immunohistochemistry will stain to detect calcitonin, CEA, and chromographine, but it will not detect thyroglobulin. And we can see in this picture, we have the follicle here, and around it we have positive staining for calcitonin antibodies. Another tool has been studied and used is to do the FNA washout fluid to measure calcitonin level, which looks like it's an important tool to also differentiate if it's false negative or thyroid biopsy. So this is a study trying to look into the calcitonin measurements in the FNA aspiration washout versus cytology examination for the diagnosis of primary or metastatic medullary thyroid cancer. So what they did, they have 38 patients with suspicious primary or recurrent MTC, and what they did FNA cytology, and they did the FNA washout calcitonin level. And that was done on 62 lesion in the neck or the thyroid. But after the final histology, they found out that about the histology was positive for MTC in 18 lesion and negative for 45 lesion. And the primary endpoint of the study is to evaluate the accuracy of FNA calcitonin washout in diagnosis of MTC. So look into their finding. FNA cytology was accurate in about 85% of the patients, 50% sensitivity and 10% specificity, whereas the FNA calcitonin level was accurate in 97% of the patients with sensitivity of 89. When they put together the cytology of the FNA and the calcitonin level of FNA, the accuracy increased to 98%, with about sensitivity of 93%, which is made about 6% of false negative when you use both cytology and calcitonin level, compared to about 50% negative, false negative when you use only cytology. So definitely adding the calcitonin washout level from the FNA, it could really help to kind of rule out MTC if they wouldn't have high suspicious. They did also the serum calcitonin ratio, as we can see here, FNA calcitonin and calcitonin from the serum. This is the ratio, which also showed improvement in the accuracy and sensitivity. But when you compare it to the FNA calcitonin and cytology was the highest accuracy and the highest risk for false negative results. In the past, there's some practice was recommend to do serum calcitonin level for almost every patient with thyroid nodule as a screening test for medullary thyroid cancer. But I think that was more done in Europe. But the agreement with this recommendation is not very strong for different reasons. First of all, because of the false positive that we can get from the calcitonin. MTC is very rare, and measuring calcitonin serum for every patient will not be cost effective. Also, normal calcitonin level could happen during the early stage of MTC, so we can miss it. And there are no prospective randomized trial evaluating the efficacy of calcitonin screening to standard evaluation for patients with thyroid nodules. So usually getting serum calcitonin just as screen for MTC has no role. So after we establish a diagnosis of MTC by histology, then we need to go to multiple of steps before sending patient to surgery. The first step we try to do, first of all, is to do the direct DNA analysis to detect the presence of RET mutation. And this should be done on all patients with MTC. Because if it's positive, then it's critical to exclude the presence of pheochromocytoma prior thyroidectomy, which is done by measuring free plasma or fractionated urine because, of course, we need to diagnose patient with pheochromocytoma and remove the tumor before sending to the surgery. Plus, we need to do like a surveillance for primary hyperparathyroidism, which include measuring calcium and PTH level. The second step before sending patient to surgery is to do ultrasound of the neck, which is the most important pre-op imaging study, which is helped to evaluate for the extent of the disease and the presence of lymph node metastasis, which of course is going to help the surgeon to determine the extent of lymph node dissection during surgery. And the third step, we need to measure serum calcitonin and CA level. It was found that pre-op calcitonin and CA level, they are useful in predicting the extent of lymph nodes involvement and distal metastasis before surgery. So also the baseline calcitonin and CA level also can predict and direct us what kind of surgery we need to do and what predict during surgery and after surgery. So this is a study looking into that concept, and what they try to do to evaluate the clinical utility of pre-op biomarker serum level, calcitonin and CA, for indicating the extent of the disease, lymph node metastasis, and the presence of distal metastasis. And they have 300 patients who are diagnosed with MTC and they went for surgery, and they did retrospective analysis to see the correlation between calcitonin level before surgery and what they found during surgery regarding lymph node metastasis and distal metastasis. So in this table, we can see that patients were divided into different groups based on their calcitonin level before surgery, from lower to higher, from 10 until greater than 10,000. And they found out that with higher baseline calcitonin level, there's larger primary tumor diameter. For a patient with a calcitonin between 10 and 20, the mean for the tumor size was between 3.3 millimeter, and it goes up to 34 millimeter with higher calcitonin level. Also, with higher calcitonin level before surgery, there was more lymph node involvement. With calcitonin level between 10 and 20, there was no lymph node involvement. With higher calcitonin level, there's a higher involvement, goes between about, with the mean 0.5 to 35 lymph node involvement. So they concluded that higher pre-op calcitonin level reflects large primary tumor diameter and a greater number of lymph node involvement. Looking to the baseline CA level, also they have like kind of similar finding with the higher level of CA level before surgery. There's a larger of the primary tumor size. With a CA level less than 4.6, the main primary tumor size was about 5.5 millimeter. Looking to between greater than 300, the largest primary tumor diameter was like 37 millimeter. Same thing with the higher number of baseline CA level. There's a higher number of lymph node involvement, and there's a less likely to achieve biochemical clearance after surgery. So they concluded that also normal calcitonin cannot exclude lymph node metastasis, nor do they guarantee biochemical cure after surgery. One last thing they look at also to the baseline calcitonin level before surgery and the compartment that the lymph node has been involved. So patients with calcitonin level between 10 to 20, they did not have any lymph node metastasis. We can see lymph node metastasis with calcitonin level higher than 20. We can see that's involved the central and the lateral compartment of the ipsilateral neck. And with the level more than 50, we can see that we have lymph node involvement to the contralateral neck side of the surgery, of the cancer. And when the calcitonin level reach 500 before surgery, we can expect to find distal metastasis. So definitely, lymph node metastasis is kind of correlate to the baseline calcitonin level before surgery, which is going to help the surgeon to decide if they want to do dissection for one side of the neck or both sides of the neck. And also it's going to help us as a clinician to predict if there's any distal metastasis with especially calcitonin level more than 500. So they conclude that lymph node metastasis was present in the ipsilateral, central, and lateral neck when calcitonin level more than 20. Also present in the contralateral central neck with calcitonin level more than 50. Contralateral lateral neck with calcitonin level more than 50. And upper mediastinum metastasis with calcitonin level more than 500. And we expect distal metastasis with the calcitonin level more than 500. The last pre-op evaluation that we need to do is to do other imaging study if metastasis of MTC is expected before op. And the most sensitive imaging study is to do CT scan, which is the most sensitive imaging procedure to detect lung and mediastinum lymph node metastasis. MRI is the most sensitive for liver metastasis. XL MRI or bone scan is the most sensitive for bone metastasis. So this is based on the ATA recommendation and their guidelines for MTC guidelines recommendation. They mentioned that ultrasound of the neck should be performed in all patients with MTC. CT scan of the neck, chest, and triphasic CT or MRI of the liver and MRI of the bone are recommended in patients with extended neck disease and sign or symptoms of regional or distal metastasis, and in all patients with serum calcitonin greater than 500. And that's grade C recommendation. Grade C recommendation means that's a recommendation based on expert experience. This is an overview diagram how to proceed with evaluation patients since the diagnosis until surgery. As we said, starting with RET mutation screening. If it's negative, then we need to check calcitonin before surgery. Level more than 500 is gonna direct us to do more imaging study for the body to look for metastasis. Less than 500, we can just proceed with thyroidectomy plus lymph node dissection. And the extent of the lymph node dissection is going to depends on neck ultrasound that's done before surgery. So usually the initial treatments for MTC start with thyroidectomy plus the dissection of cervical lymph node compartment is the standard of care for patients with MTC. And of course, the extent of lymph node metastasis is going to depend on the neck ultrasound and pre-op calcitonin level. This is also a recommendation from the ATA for MTC guidelines management. Mentioned that the patient with MTC with no evidence of neck lymph node metastasis by ultrasound and no evidence of distal metastasis, they should go for total thyroidectomy and dissection of the lymph node in the central compartment only. And patient in MTC had no evidence of net metastasis on ultrasound and no distal metastasis, the dissection of the lymph node in the lateral compartments may be considered based on calcitonin level, and usually that's more than 200 when we do the lateral sides. And the last recommendation mentioned that patient with MTC confined to the neck and with lymph node metastasis, they have to go for total thyroidectomy plus dissection of the central lymph node and the dissection of the involved lateral neck. But when the pre-op imaging is positive for the ipsilateral lateral neck compartment, but negative for the contralateral neck compartment, the contralateral neck dissection should be considered if the basal calcitonin level greater than 200. Just to make it easy, let's say a patient has a thyroid nodule MTC in the right side. They have to go to the central lymph node dissection plus lateral, but only we consider to go to the other side of the neck for dissection only of the calcitonin level more than 200, because we expect that contralateral of the neck vein gets metastasis with a higher level of calcitonin level. Other approach for the surgical management, especially for a patient with advanced or metastatic disease, in this situation with a patient with advanced disease, which means that MTC has invaded the trachea, the thyroid cartilage, or the esophagus, the goal of surgery is more palliative with attention to minimize complication. And the extent of surgery, like palliative debulking, laryngectomy, esophagectomy, or laryngopharyngectomy, is determined by an assessment of the ability to maintain speech of the patient and swallowing of the patient. And also we should consider the patient life expectancy based on the extent of the disease and other medical comorbidities. So from the ATA guidelines also, in the absence of, in the presence of extensive regional or metastatic disease, less aggressive surgery in the central and the lateral neck may be appropriate to preserve speech, swallowing, and parathyroid and shoulder morbidity. In case we need to avoid surgery or minimal surgery, then we can do radiation therapy or systemic surgery, or systemic medical therapy to achieve the, disease control. So after the patient went, let's say patient went into thyroidectomy, lymph node dissection based on the extent of the involvement, the first step post-op is, of course, to start hormone replacement therapy. And we should not suppress TSH level, similar to the differentiated thyroid cancer, because since MTC is not follicular neoplasm. And of course, we need to monitor for post-op hypocalcemia. Next step, after surgery, we need to monitor and measure post-op calcitonin and CA level. And usually 3 months post-op is the optimal time to determine the nadir of serum calcitonin CA level. And post-op calcitonin and CA are very important marker in the post-op period to determine if surgery has been cured or not. And also they play as a prognostic marker to determine if the disease is going to recur in the future or not after surgery. And usual surgery can be considered as cured if the calcitonin level after surgery is indetectable or less than 10. So this is a study. They're looking into the post-op calcitonin level and its association with survival or with recurrence of the MTC later on. So they had 63 patients with MTC without distant metastasis who underwent total thyroidectomy and lymph node dissection, and they had normal post-op imaging study. And what they did, they followed this patient for 6 months to measure calcitonin and CA level, and also they did annual neck CT scan. And the aim for this study is to do like an analysis to evaluate the 3-year and the 5-year relapse-free survival. Relapse-free survival, which means the time of surgery until the recurrence of the disease happened. And also to identify if there's any prognostic factor for the relapse based on the imaging. They have different prognostic factor. If we can look at here to the calcitonin level post-op, patient who had undetectable calcitonin level after surgery, they had 93% 3-year relapse-free survival and 90% 5-year relapse-free survival. Compared to people who has detectable calcitonin level, they had 78% and 61% of 3-year and 5-year relapse-free survival, which is significant p-value. Similar, patient who did not have any lymph nodes involvements at the time of surgery, they have almost 100% 3-year and 5-year relapse-free survival, which is good prognostic. Compared to people who had like lymph node involvement, they have between 78 and 65% 3-year and 5-year relapse-free survival. So from this study, looks like calcitonin level after surgery can really predict for how long the patient can survive without any recurrence. Also, very important marker after surgery is to check for the doubling time of serum calcitonin and CA level. The doubling time of calcitonin and CA level means that we need to measure serum level of calcitonin and CA over multiple time periods, usually every 6 months, to determine the rate at which its marker value double. Shorter doubling time usually associated with faster MTC growth and worsening prognosis. So the doubling time of calcitonin and CA level has been a very useful tool to determine the MTC growth rate in patients with recurrent and persistent disease. So this is a study also looking to that prognostic factor, where they try to assess the prognostic value of calcitonin and CA doubling time in 65 patients with diagnosis NTC who had abnormal calcitonin level after total thyroidectomy and lymph node dissection, and they followed these patients for between 2.9 to 29 years, and they tried to assess the doubling time as a prognostic factor for 5 years and 10 years survival. And what they found that if the doubling time of the calcitonin was more than 2 years, which is slow doubling time, that associated with 100% survival rate in 5 and 10 years. Whereas doubling time, which is kind of faster, less than 6 months, that's associated with 25 and 8% of 5 years survival and 10 years survival. So faster doubling time is associated with worsened prognosis and less survival time, compared to doubling time more than 2 years that should be associated with good prognosis. So they said that as a result, all patients with calcitonin doubling time more than 24 months were alive at the end of the study. Whereas the 5-year and 10-year survival rate in those people with doubling time between 6 to 24 months were 92% and 37%. But the people who had doubling time less than 6 months, they have 5 and 10-year survival rate between 25 and 8% of the time. So this is kind of a diagram shows us what to expect after surgery, and we can risk stratify our patients. Either patient after surgery they had an excellent response to surgery, which is mean that the patient has normal range of calcitonin and CA level with no evidence of structural disease. And this patient who has like a kind of, we can say they have a cured disease, we can follow them with calcitonin every 6 months, then every 1 year, and then we can do ultrasounds every year as well. But patient who has biochemical incomplete response, which is mean patient has surgery, but after surgery they still have detectable calcitonin level and abnormal CA level, but without any evidence. So this patient, we can consider them they still have persistent disease, they're not cured, but we still cannot identify the location of the persistence of the disease. So this patient, we need to continue monitoring the calcitonin and CA level every 3 to 6 months and try to calculate the doubling time, and also check ultrasound every 6 months of the neck, and until we can identify the location of the recurrence, so we can go to the next step of the management. Whereas patient who has a structural incomplete response, which is the mean patient went to surgery, but they still have residual disease. And with follow-up, patient either can have like stable disease or they can have a progressive disease. And we can manage based on the situation that we're dealing with. So we're going to go more about the treatments after going for surgery, especially in patient who has persistence or recurrent disease of the MTC. Patient went to surgery, has surgery done, lymph node dissection, but they still have detectable calcitonin level without any structure evidence of disease recurrence or imaging study. For this patient, we just need to follow up with them and try to measure calcitonin and CA level every 3 to 6 months. And usually there's no recommendation for any intervention, just based on increased calcitonin level without any evidence of structural disease on imaging study. Whereas patients who had surgery but they still have local regional disease on imaging study without any distal metastasis, this patient, they can go underwent a recurrent surgical resection for their persistent disease with or without a post-op radiation therapy. Whereas patient who has unresectable disease, patient has like extensive neck disease, not able to resect all the tumor, for this patient, we may do like palliative surgery, or they can be managed with radiation therapy or systemic therapy. Right now, I'm going to go over the systemic therapy, the external beam radiation therapy, for a patient who still have persistent disease after they went into surgery. So external beam radiation therapy to the neck is usually recommended for a patient to prevent local recurrence in patients with high likelihood for tumor recurrence following surgery. Example, patient went to surgery, had thyroidectomy, complete, removed, but we still have a concern of recurrence. We can do radiation therapy to decrease the risk for recurrence later on. Also can be done radiation therapy for patients with locally persistent or recurrent disease who are not candidate for reoperation. Also, radiation therapy can be done as a palliative treatment or for unresectable tumor, like patient with extrathyroidal extension or extensive lymph node metastasis. The issue with radiation therapy, that the benefit of external beam radiation therapy after thyroidectomy in patient with MTC is kind of difficult to evaluate. Is going to be good as a prognostic and prevents recurrence, because there's no clinical trial that has been done to evaluate there's no critical trial has been got patient and randomized patient, and they compared patient who got into radiation therapy compared to a patient who went to observation alone. This is one of the studies that I found. It was evaluating the role of radiation therapy in the management of advanced MTC. This is Mayo Clinic experience back in 2013. And what they did retrospective review of the data for 17 patients with MTC who received radiation therapy after thyroidectomy between 1970 and 2007. And the endpoint of the study to evaluate survival and local regional tumor control rates. So they have a total of 17 patients. They divide them into 3 groups. First group, there are 6 patients who received initial adjuvant radiation therapy after neck surgery. The second group, 5 patients who underwent radiation therapy after recurrence of a disease after the failure of the first surgery, and 6 patients who underwent radiation therapy for palliative, for metastasis disease. So regarding the first group who had radiation therapy right after thyroidectomy, they found out that all the patients did not have any recurrence of the disease during their follow-up. All patients achieved disease control with no recurrence during duration of follow-up, with the median duration of follow-up was between 1.8 to 21 years. The second group who had radiation therapy after they had persistent disease or recurrent disease after thyroidectomy, they found only 3 patients who were able to achieve disease control after follow-up between 3.4 years and 18 years. 1 patient, he died due to intracranial bleeding unrelated to treatment, and 1 patient had recurrence after radiation therapy after 54 months. And the last group who had palliative radiation therapy for metastatic disease, they mentioned that this treatment provided documented sustained relief of symptoms in about 45% of the irradiated sites. Looking to the 5-year overall survival, the 5-year and 10-year survival was 44% and 19%. So they conclude from the study that medullary thyroid cancer appears to be a radiosensitive tumor. External beam radiation therapy may be more effective in adjuvant setting for the prevention of local regional recurrence. But it may also have a role in providing durable and sustained control of the local regional advanced and metastatic disease. I found multiple studies looking to the same things about the benefit of radiation therapy after surgery, and the patient who's benefited the most, people who had successful surgery with no residual cancer, and they have radiation therapy, and this patient has longer period of free recurrence of this cancer. No, without any evidence of disease. Some patients just got radiation therapy without any evidence of recurrence. For localized, and they usually do it for a patient who has high risk for recurrence, like a patient with family history of MTC, many people. high calcitonin. Also during the operation, the surgeon, based on their experience, they feel like they did not remove all the lymph nodes, so they just do radiation therapy right after surgery just to increase the survival rates. Whereas the treatment for a patient with advanced and metastasis MTC. Advanced MTC, which means that with MTC invites different part of the neck, like the trachea, thyroid cartilage, and esophagus. And MTC usually goes and metastasizes to different regions like the brain, the lung, liver, bone, especially the spine, and cutaneous tissue. Usually for a patient who has like isolated one metastasis, they can be treated either by surgical resection or by radiation therapy. But patient who has multiple metastases or not candidate for surgery, they can be then considered for systemic therapy. And now I'm going to move forward with a discussion about the use of systemic therapy for treatment for a patient with metastasis MTC and advanced MTC. So as we mentioned earlier, that MTC is highly associated with RET mutation. And the idea of systemic therapy is basically to block the tyrosine kinase receptor and to block their intracellular pathway, which usually promote the MTC pathogenesis. So there's multiple tyrosine kinase receptor inhibitor that's been developed in the market. The function of this medication is to block the tyrosine kinase receptor to prevent the downstream signaling, which is usually lead to MTC developments. So the FDA has approved two oral tyrosine kinase medication. The first one called vindatinib, and the second one capuzantinib, for patients with advanced MTC. And there's also approved for patient with unresectable tumor, patient with locally advanced tumor, and metastasis MTC. So vindatinib is the first approved FDA tyrosine kinase for medullary thyroid cancer. It was approved in 2011. And the mechanism of action, it's a multi-kinase receptor, which means it blocks 3 different kinase receptor. The first one is RAT. The second one is epidermal growth factor receptor. And the third one is vascular endothelial growth factor receptor. So it works in 3 different tyrosine kinase as a mean of mechanism of action. The dose between 100 and 300. And because it works on like 3 different receptors, the side effect is high, which is usually one of the most concerned that when we start patient on tyrosine kinase inhibitor are the side effect, which usually can be skin reaction, fatigue, interstitial lung disease, stroke, GI side effect, nausea, vomiting, hypertension, renal failure, delayed wound healing, heart failure, and prolonged Q2C interval. Contraindication to use this medication for a patient who has a serious cardiac complication, like patient with a congenital long QTC syndrome, and patient with uncompensated heart failure. So as I mentioned, that vindatinib has been approved in 2011 based on this phase 3 clinical trial, where they involved 331 patients who had unresectable, locally advanced, or metastasis MTC, who had been diagnosed with hereditary or sporadic MTC. Either they have a RET mutation positive or negative. And they were assigned and randomized into 2-to-1 ratio to receive oral vindatinib 300 milligram versus placebo. And the primary outcome of this, the primary objective of the study is to determine whether vindatinib compared to placebo is going to lead to prolonged prognosis-free survival. Prognosis-free survival, which means the time between treatment until tumor progression occur. And they found from that study that a patient who were on vindatinib, they have a longer free prognosis. They have a longer prognosis-free interval. They have almost 30 months for vindatinib group compared 19 months for the placebo group. but they found that there's no significant association was observed regarding overall survival in this two group. So Vintanamib lead to delay the progression of the disease compared to the placebo, but did not have any significance regarding overall survival. Regarding side effects, the most common side effect that has been found was GI side effect, diarrhea, rash, nausea, and hypertension, 32% of the patients, plus 14% of the patient has EKG Q2 prolongation. The second tyrosine kinase inhibitor is cabozantinib. It also was approved in 2012. It also is a multi-kinase receptor inhibitor. It works on 3 different receptors: the RITs, tyrosine kinase, and the vascular endothelial growth factor receptor, plus the MAT, which stands for the mesenchymal epithelial transition factors. So it's also multi-kinase. The dose, recommended dose is 140 milligrams twice a day. It has also significant side effect, which is most common: skin reaction, fatigue, GI side effect, hypertension, thrombotic effect, hepatotoxicity, headache, and delayed wound healing. It's usually contraindicated with a patient who has a recent GI hemorrhage, because cabozantinib has been increased the risk for hemorrhagic events and the GI fistula formation. So as I mentioned, it was approved in 2012 based on this clinical trial, which is a class stage 3 double-blinded study, where they enrolled 300 patients who have confirmed unresectable, locally advanced, or metastatic MTC, also with hereditary or sporadic MTC, and also they randomized them into 2-to-1 ratio, one group to get oral cabozantinib 140 milligram BID or placebo, and the primary objective of the study also to check the duration of the progression-free survival. Plus, they look into overall survival as well. So comparing two groups, regarding the overall survival, the cabozantinib group have a median overall survival of 26 months compared to the placebo group 21 months, which was with non-significant p-value. Looking to the progression-free survival, also the treatment group had about median 11.2 months compared to 4 months for the placebo group, with significant p-value. So again, cabozantinib has significant effect on the progression-free survival, but not that much regarding overall survival. But what they did, something significant in this study, they did sub-classify this patient they have into 2 groups. One group who has RET mutation positive, and the second one has RET mutation negative. And they try to compare these 2 groups to each other. So regarding patient who has RET positive, mutation positive, the overall survival was significant for this group. As we can see, the median overall survival was 44 months compared to 18 months for the placebo group, with significant p-value. Whereas the people with RET negative mutation, they did not have like any significant overall survival. Similar to progression-free survival, people who has RET mutation positive, they have a significant difference, with the mean progression-free survival of 13.9 months of the treatment group, 4 months for the placebo group, with significant p-value. What they conclude from this study, that patient with RET positive tumor may experience a greater treatment benefits with cabozantinib compared to patient who has RET negative, regarding overall survival and progression-free survival as well. 2 new tyrosine kinase inhibitor also was approved by the FDA in 2020. The first one called selpercatinib, and the second was pralsetinib. The difference of these 2 tyrosine kinase from the previous 2, that they are highly selective RET kinase inhibitor. So they only inhibit the RET kinase inhibitor compared to the previous 2 who work on 3 different receptor kinase. They are very potent to inhibit different RET alternation with lower toxicity. It was approved only for patients with positive RET mutation, MTC, based on phase 2 clinical trial. Right now, there's multiple ongoing phase 3 clinical trial that's been comparing these two medications compared to capozanib and ventanabib in patients without prior tyrosine kinase receptor therapy in RET mutation only patients. So this is a recent study that was published in April 2022, phase 2 clinical trial, which is looking at the efficacy of this highly selective tyrosine kinase inhibitor, selpercatinib, where they have 55 patients with RET mutation, MTC, who has been previously treated with ventanabib and capozanib. And they have 88 patients with positive RET mutation, but did not receive any previous treatments. The patient received 160 milligram twice daily, and the patient was being followed until progression occurred. And the primary endpoint of this study was to check the tumor response rates, which means how much the tumor shrank after starting the treatment, which is they did according to the response evaluation criteria in solid tumor guidelines. And the second endpoint was to look for the progression-free survival and duration of response and safety. So what they found out in the first group, that patient who has RET mutation was previously treated with ventanabib and capozanib, that complete response was achieved in 9% of the patients. Complete response, that's a tumor completely shrunk, and it's not appearing in the imaging study. Partial response was achieved in 60% of the patient. Partial response, which is mean the tumor shrunk by more than 30%. Stable disease was achieved in 25% of the patients, and stable disease means that the tumor size has been stable. Progressed disease was found in 2% of the patients. The duration of response was 14.1 months, and the progression-free survival was 16.7 months. Compared to the patient who did not receive any prior tyrosine kinase, also complete response was achieved in 10%, partial response in 61%, stable disease in 23%, and progressive disease in 2%. The duration of response was about 7.8 months, and the progression-free survival was 11.1%. The side effect was noticed also dry mouth hypertension. They categorized the hypertension severity based on different grades, grade 1, 2, 3, 4, and 5. Grade 3 means like severe hypertension. Grade 4 mean life-threatening hypertension or side effects. So hypertension was overall developed in 30% of the patients, 12% only severe. Other side effect was fatigue, increased liver enzymes, AST and ALT. Other side effects was like less common. Other possible that we can use other than the tyrosine kinase receptor treatment, we can use also the cytotoxic chemotherapy. Cytotoxic chemotherapy can be used as a single agent or as a combination. And the most effective regimens are combination therapy with doxorubicin, with any other agent, or we can use 5-fluorouracil and dacarbazine. But over the past 10 years, chemotherapy with cytotoxic agent has not been really used, especially since the development of tyrosine kinase inhibitor. Plus, this treatment option is not the first line treatment, because usually this response rate with this cytotoxic chemotherapy is low. About 15 to 20% of the patients can respond to treatments. Newer emerging systemic therapy using the immunocheckpoint inhibitor. We already know that immunocheckpoint inhibitor has been established as a treatment for several types of malignancy. But do they have a role in treatment for medullary thyroid cancer? So there's a study was recently published, I believe like in 2020. They looked into 200 patients with MTC, and they found that these patients, they showed that they have programmed cell death protein PD-1 positive was detected in 13% of the patients. And also, the cytotoxic T cell lymphocyte antigen 4 was positive in 12.5%. So this finding is very promising in the treatment of MTC using immunotherapy. Right now, there's no recommendation or guidelines regarding using immune checkpoint inhibitor, but there's about like 3 or 4 ongoing trials that are currently active, studying the use of immune checkpoint inhibitor in progressive MTC patients. And that's the end of my talk, and thank you so much. Okay, so this is a question about we mentioned that we use scintigraphy to detect metastasis for MTC to bone. Why not PET and bone biopsy and CT scan? Based on my understanding, that usually PET scan less sensitive to detect bone metastasis. When we talk about bone metastasis, the most sensitive imaging study is MRI or bone scan. PET scan is usually more sensitive for diagnosis like solid tumor in the organs. Similar for CAT scan. CAT scan is not going to be as sensitive and accurate compared to MRI for diagnosed bone metastasis. Other question, in non-surgical intervention considered before thyroidectomy? If yes, what would it be? If non-surgical intervention considered before thyroidectomy. If a patient, let's say if there's any non-surgical treatment considered before thyroidectomy, let's patient have a disease and any treatment. I've not seen any recommendation regarding using radiation therapy before thyroidectomy or using chemotherapy or tyrosine kinase before therapy, because possibly the surgery could be curative and there's no need to use all this other intervention, radiation or chemotherapy. So for that reason, first step, surgery, and then based on follow-up calcitonin level ultrasound, we can determine if the patient needs any further intervention if they have recurrent disease. Any question? Dr. Kirsch, question?
And so from what I know and the few patients that I have, a couple of them are shared with MD Anderson. Your surgeon is your best. You want to have the best surgeon. Because getting the bulk of it out is a big difference.
Correct.
The patient I had, she's 30 years now, and she's interestingly not very positive, erratic. Her recurrent surgery has been done. She's had radiation, and right now she is on, I think, one of the TKIs, the multikinase. But they shaved off almost as close as possible to the trachea. It's almost there. But they went back again and again and again. And it's been very successful. She's had some swallowing trouble, some sort of oral pharyngeal issues. But in terms of quality of life, she's overall doing excellent. She's seen there twice a year, and I follow her twice a year here between all of us, and a local oncologist. She's done really well. 35 years now.
Gotcha.
With local meds and also lung meds.
Yeah, this is a good point, because they mentioned that people with advanced locally disease, as like extended disease, metastasis, the role of the surgeon is very important to remove as much as possible from the cancer, trying to maintain the speech and the swallowing and avoid parathyroid damage. And correct.
Not routine. In the past, we talked about thyroglobulins,
calcitonin staining. They usually don't do it unless a patient has a negative biopsy, and we think the patient has a high risk for MTC regarding patient has a family history, or they have like a RET mutation, suspicious thyroid nodule. So if there's all the information tell us possibly they have MTC, but the biopsy is negative, then calcitonin staining or calcitonin measurement using the FNA washout level, that's going to improve the sensitivity and improve the accuracy of the diagnosis. What they do, the same needle that we do the biopsy, they just use like 0.5 ml of like saline, and they flush it like in a tube, and this can be used for measuring calcitonin.
We've done stains in the past, very long time.
Yeah, I think not common. So.
It's not very common to use it. Because from the beginning, cytology and FNA almost more about 80 or 90% accurate to get the diagnosis.
Better that even the family is for accuracy.
Dr. Winters, have any questions?
Dr. Winters, do you have any question for us? You're muted.
You're muted.
Yeah, my question too is about the 10% of people who would have false negative FNAs. And I think very often the cytology technician will take a small aspirate if there's enough sample, and just save it.
Yes.
And so they freeze it. So more often you may not be aware of them preparing to have that done because one of our former pathology faculty members wrote a paper about that, about doing the calcitonin analysis of the fluid aspirate some 10 years ago. She went to NYU after leaving Louisville. So they're tuned into it in our place.
Sure. Thank you.
That was a very good talk anyway.
Thank you so much. Okay, thank you so much.
Okay.
Have a wonderful day.